Good afternoon, and welcome to today's Side by Side with the Division of Mental Health, Developmental Disabilities, and Substance Use Services, Improving Our System Together monthly webinar. Before we get started, here are a few reminders about the webinar technology. Please make sure you are using a computer or smartphone connected to the internet and the audio function is on and the volume is turned up. Please make sure your microphone is muted for the duration of the call unless you are speaking or asking questions. Questions can be submitted anytime during the presentation using the Q&A feature located on your control panel. We will answer as many questions as time allows toward the end of the presentation. American Sign Language interpreters and closed captioning options are available for today's event. The American Sign Language interpreters for today are Danette Steelman-Bridges and Callie Marsh. For closed captioning options, select the closed caption feature located on your dashboard. To adjust your video layout and screen view, select the view feature located in the top right-hand corner of your screen and choose the view that works best for you. Today's agenda topics include introductions, announcements, mental health, substance use disorder, intellectual and developmental disabilities, and traumatic brain injury system updates and supports for justice-involved individuals. There will also be time for questions at the end of the presentation. At this time, I'd like to turn it over to Kelly Crosby, Director for the Division of Mental Health, Developmental Disabilities, and Substance Use Services.
Thanks so much, Tina. Hello, everyone, and welcome today to our side-by-side webinar. My name is Kelly Crosby, and I am the director here at the Division of Mental Health, Developmental Disabilities, and Substance Use Services. Just a quick intro to me if you haven't met me. I've been in this field a very long time. For about 12 years, I've been at the department. 11 of those years were actually spent at the state Medicaid agency, and I've been with the Division of Mental Health, Developmental Disabilities, and Substance Abuse Services almost a year now. I have been in this field working with all of the populations that our division supports for over 25 years. I am a licensed clinical social worker. I'm super proud of that. And I'm a person with my own lived mental health experience. I've got lots of family members with mental health, substance use, justice involvement, and intellectual and developmental disabilities. Like many of you, I do this because it's very personal to me. So thank you so much for joining us today. All right, the first thing I'm going to start with are actually just some general announcements. The next side-by-side webinar will take place in January, so after the holidays. And at that one, we will focus on behavioral health and IDD workforce. As you recall, we've been spending our time every month going through all of the new budget allocations that were given to us by the General Assembly. And I'll break that money down for you a little bit. We've already gone through crisis, which was last month. We're doing justice today, justice supports and services. And in January, we'll talk about workforce investments for both behavioral health and IDD. February is yet to be determined, but we actually might break that January session up into two because we're focusing on some workforce initiatives around peer support services and also some workforce supports for direct support professionals. So we may break that up into two sessions. On the next slide, I just want to remind folks about our whole communication approach. Every month we will do the side-by-side webinars, and that's really high level. I'm going to present some information here. We'll leave time for question and answer, and then we'll cascade the same topic down into our 4 standing work groups that we have every month with our State Consumer and Family Advisory Council, our LME MCL Clinical Working Group, our meetings with providers and provider associations, and our meetings with the Healthcare and Hospital Association. As a reminder, we have specific advisory groups around all these particular budget initiatives. We actually had our first advisory groups for our justice funding, our crisis funding, and our workforce funding, specifically in the area of peer supports. Our direct support professional workforce advisory group starts in 2 days. And you will see the dates for all of the next meetings. If you're not involved in these, you are welcome to. The same email you would email to get an invite for this, you can feel free to email us and someone will put it in the chat too. If you're interested in belonging to any of our routine monthly meetings or any of these time-limited advisory groups around the budget initiatives. The last thing we wanted to share today is how to join your local CFAC if you were interested. Lots of folks want to know how to become involved if they are a consumer or a family member of a consumer of services and supports in our systems. We're really excited. We get that question a lot. So we just wanted to make sure in our slides for today that folks knew how to reach out to individual LME MCOs if they wanted to be a part of their local CFAC. So here's a contact for each of the LMEs. Excited that folks want to get involved, and please do. Next slide. Now I'm going to do some mental health, substance use, intellectual and developmental disability, and traumatic brain injury system updates. So a lot of this is a recap of announcements that I hope that you've seen already, but I do want to make sure that we go through them. Some of them are huge announcements, and I want to make sure that everyone has seen them. In these slides as well, we have a lot of links for the places you can find a bulletin or a hot topic or the document itself. So the first thing I'm going to remind folks of is Medicaid expansion. So hopefully this is not news to anybody. After really 14 years, we have Medicaid expansion here in North Carolina. It's truly a tremendous and wonderful thing. Big kudos to the secretary, to the state Medicaid agency, to all of our community partners, all of our sister divisions in the department. This is just a really wonderful day for North Carolina. So in other trainings and in our partner meetings, we have shared some of the Medicaid expansion documents that we hope help people learn more about Medicaid expansion and know how to sign up for Medicaid. So this visual is just a picture of the one pager that explains Medicaid expansion and income levels and the kind of services you can get under Medicaid. On the next slide, here are some, that's our one pager in Spanish. And there's a YouTube video there that walks people through the ePass system, which is a system where folks can sign up themselves for Medicaid online. So that's actually a walkthrough. It's a long video, but it's a really nice walkthrough of everything. So thanks to everyone. Thanks to all of you who are getting the word out to family, friends, community members, if you're providers, the people that you're supporting, thank you for doing that. Use these one-pagers, share this video with your staff and with the people you support, because we'd really like to get people signed up for Medicaid. 300,000 people have been enrolled already, right? So folks who had a more abbreviated form of Medicaid now have a full Medicaid benefit. And we're so excited about the folks who can get healthcare, medications, have hospital stays paid for, and to get mental health and substance use services and HCBS services. So super, super excited about this opportunity for folks to have services and supports that help them live a full life in the community and move and maintain recovery. All right, so that's our biggest announcement. Another big announcement, which is huge and exciting. We talked about this last month. Remember, you got the sneak peek. We released our 988 performance dashboard. So North Carolina is a leader in 988 performance. We're doing really well, and we really want to be transparent. We're collecting lots of data about who's calling every month, why they're calling, what the disposition of the call is, because it helps us understand the system better and prepare that system better. Remember, we got about $113 million to spend in the crisis system, and this 988 data helps us to understand our system a little bit better. We've got well over now, because this data only runs through when does this data run through? This ran through October. We were probably close to having 100,000 callers now. And remember, this dashboard will show you information on who's calling and why they're calling and the type of services and supports that people are being referred to. We will refresh this every month. There are hot links in this webinar to show you both the press release that came out from the department today and also the dashboard that's on our website on a routine basis. Next slide, another huge announcement that we've talked about already. Medicaid published their behavioral health rate increases. This is the first time we've had rate increases of this magnitude for at least a decade. And this is a tremendous investment. We are very excited about this. All rates were not increased the same, but overall rates were increased about 20%, which is extraordinary. In some places, like for outpatient services for therapists, assessments for therapists, psychological testing and evaluation, psychiatrist services, we were able to increase the rates to Medicare rates. In other places, we were just able to increase the base rates for services. But the goal really was, we want to be able to recruit licensed folks to come and work in the behavioral health field because we have better comparable rates to maybe the private system. We increased hospital rates tremendously because we want hospitals to open up more of their licensed psychiatric beds so folks aren't waiting in emergency departments. We've invested in more community-based services, so hopefully people will get stabilized in recovery-based services in the community to avoid crisis in the first place. So these investments are very exciting. They'll go into effect January 1st. We have a hot link for the Medicaid bulletin that explains the services that were increased. And we are looking forward to see how these rate impacts affect the system. Remember, these are recurring dollars. So we will get to increase rates year over year, which is really, really the kind of fundamental investment we need in our behavioral health system. On the next slide, we also got some other rate increases. So we got direct support professional DSP rate increases, specifically for the innovations waiver. There's a hot link there to the Medicaid bulletin. As a reminder, we talked a couple of months ago about the General Assembly did give us $106 million in recurring funds for direct support professional wages. The Medicaid agency dropped those into a list of rate increases for innovation services. There's the list right there. It's residential supports down through supported living. So a lot of our community-based services under the waiver. Providers, because of the way that the funding was written and established, providers need to commit to using the rate increases to support direct care workers. So that language from the bulletin is copied directly here. So again, we will be collecting more information from LMEs and from the field to understand the rate increases that are getting to providers, and then over time to understand how is that affecting, hopefully positively, the availability of direct support workers for folks who are receiving both innovations waivers, but also I-option services and state-funded home and community-based services. Next slide. I think this is our last announcement before we move into today's topic. So I wanted to just remind folks, I think you're all very well aware that our LME MCOs are consolidating into 4. You've seen this slide before, but I just want to remind folks as we're about to enter this time of change, we're always in times of change, aren't we? That as the secretary was thinking through how to consolidate the LMEs, he did talk to community stakeholders because he wanted to understand what was of highest priority for everyone as he made consolidation decisions. He went forward with some guiding principles, which he shared with the community, which are what is best for the people that we serve, what will get us to tailored plans quickly. And remember, the vision for tailored plans is whole person care, having a one-stop place for everyone to get their physical health, behavioral health, pharmacy all in one place. And then he wanted to reduce complexity in the system and minimize disruption as much as humanly possible. As a reminder, Sandhills and East Point already had made a decision to request to consolidate, and the secretary granted that. And he also asked that East Point, which is the surviving entity, consolidate with Trillium. There were 3 counties excluded from that went to other LMEs, and you will see that here on the slide. And all the LMEs were asked to develop transition and consolidation plans, including East Point and Trillium. Now, this is still high-level information that talks about the principles and the general ways, the counties that will change under this consolidation agreement. Later this week, we are aiming for later this week to release some FAQs for providers and consumers that talk about concerns around contracts and around the continuation of services, the continuation of your case manager, what you're going to do about your Medicaid card. So all of those really critical things that you want to know as a consumer or a provider, we'll be releasing some of those later this week. And like everything that we everything that we produce. If you're like, well, that's helpful, but I still have 15 more questions, please get them to us. We'll do more FAQs. We'll have more trainings. We'll have more opportunities for feedback and questions. We want this to go as smoothly as possible. All right. So with that, I am going to move into our main topic today. So as a recap, last week we talked about our crisis investments. Today, we are going to talk about mental health, substance use, intellectual and developmental disability, and traumatic brain injury supports for justice-involved individuals. And I want to tell you something. We're going to do an overview, right? So first, we're going to kind of ground ourselves into why. Why are we even talking about mental health and substance use supports for people involved in the justice system? Why? What's the data that we see? What do we know? What do we know in North Carolina? What do we know nationally? And then we're going to spotlight some specific things that we fund now. We fund many things, as you will see. We don't have time to showcase them all today, but we wanted to bring forward some specific examples because we want everybody to understand the value of and the reason for these programs. And again, we want to work with our advisory committee to get some really concrete feedback on what is the best way for us to use these service dollars here in North Carolina. So remember, we're going to kind of do an overview, and then we're going to spotlight a few of the key programs that we currently fund. All right, so on the next slide, I actually want to start today with a bit of a scenario, and I use this scenario when I present. I actually use this when I present to high school students a lot. And this is a composite. It's Daniel's not actually a real person that I know of. This is kind of a composite, but it's very real. So I want you to imagine a man named Daniel. He's 28 years old. He needs mental health treatment and medications. He doesn't have health insurance. Surprise, surprise. And let's hope now that Daniel and the Daniels of the world are getting health insurance. But up until this point, he hasn't. He falls into that gap, right? Where he does not have the health insurance he needs to maintain recovery-based mental health services and his medications. Several months ago, Daniel experienced a mental health crisis. He called 911, or a loved one called 911. First responders came, and Daniel had not been able to have his treatment or his medication for some time. He was arrested, unfortunately, and he did lose his job, though his job didn't have benefits. This happens all the time. This is a composite, but it's a very real example. So where's Daniel right now? Daniel is currently stuck in jail, and he is waiting for an inpatient psychiatric bed. Why is he waiting for an inpatient psychiatric bed? We're going to talk that a little bit later in the slide. But he needs treatment while he's incarcerated in order to even be able to stand trial so he can eventually serve his term and go home. But this is the situation that people find themselves in a lot. They needed treatment. They didn't get treatment. They were arrested instead of diverted or directed into treatment. And now he's waiting, incarcerated, and still needs treatment. So we're talking about a young adult here who's needed treatment for some time. If Daniel had been able to get treatment early, potentially much of this had been diverted. Now, on the next slide, I want to show you something that there's a lot of experts here today on the call that know this already. But for the rest of us, right, let's talk about why we need a strategy around mental health, substance use, intellectual and developmental disabilities, traumatic brain injury, and justice. This is startling, y'all. 60% of individuals in jail report symptoms of mental health issues in the last year. 83% of individuals in jail with mental illness did not receive mental health care after they were admitted. 68% of people in jail have a history of misusing drugs or alcohol. Now, this one is really sobering and painful, y'all. Compared to other North Carolinians, within the first 2 weeks after incarceration or after release, formerly incarcerated people are 40 times more likely to die from an opioid overdose. Sobering, right? We've talked in many webinars about how 1 in 4 folks, 1 in 4 of us, all of us, deal with mental health symptoms at some point in their lives. Pretty common. This is even higher, right? So you just can't avoid the fact, nor should we want to avoid the fact, that people who are incarcerated often have mental health or substance use issues. So on the next slide, I want to introduce again, remind folks again, okay, so those are some of the facts, right? We talked about Daniel and his case. We talked about some of the facts we know about people who are incarcerated and the number of mental health and substance use issues they might have. This is just a reminder that we got $99 million. This is the slide we show every month. We're looking at the justice line. We got $99 million to use to the best of our ability on the most effective initiatives in the justice space that we can. On the next slide, again, there are experts on the call today who are very used to looking at this. This is a beautiful diagram. It's a busy slide. It has a lot of things. But we do fund a lot of programs here in the state. We do, our division does. Federal grants fund things. We use state dollars as well. There's other funding sources that come into the state. And we all use something called, well, hopefully, we think about funding along something called the sequential intercept model. What is that? I remember when I first heard it, I was like, what is that? We've got experts today on the call, like Sarah, and Stella, and Tracy, and they were quite familiar with SIM. But the sequential intercept model, and I'm telling you this for a reason, it details how people with mental health and substance use disorders can come into contact with and move through the criminal justice system. So there are many points of intersection with the justice system, and that means many points of intervention. That's what that means. So we try to collectively as a nation, here as a state and as a nation, kind of use this model to say, these are the different places at which we could impact this person's journey and get them into treatment, rather than have them either go into or maintain into the justice system or even be reincarcerated. So you have a very busy slide. I'm not going to walk through this whole slide, but I want folks to see it and know it because we talk about the SIM a lot, the sequential intercept model. We talk about it a lot. And there are some programs listed here that we fund. So we wanted to share with you along the model, where do we try to fund things? And you will see that all along the model, we actually fund services all across the model. And it starts with Intercept 0, which are just having things like 988, a crisis line, and mobile response teams, alternative crisis responses to maybe first responders. So we have those. Intercept 1, we're going to talk about Intercept 1 and 2 in the next slide. So we're going to talk about places we can divert people or deflect people or divert people from the justice system. We'll talk about those in the next slide. Then there are places that we fund treatment while someone is incarcerated. Then we fund services while people re-enter after they were already incarcerated, re-enter into the community. So we're going to talk about things that we fund along the intercept. And so one of the things that we're talking about with our advisory committee is, where are the most effective places for us to intervene or that have the most effective models in these spaces? So this is where I'm going to spotlight just a couple. Not going to do them all, but I'm going to spotlight a couple. So on the next slide, we are going to look at something called deflection, and diversion. So remember I showed you the intercept 0 through 5, all those stages where someone could be deflected or diverted or treated while incarcerated or helping get reentry services. We're going to talk about that first end right here. We're going to talk about deflection and diversion. So what the heck is deflection? Deflection is when an individual might have an initial interaction with law enforcement or first responders. So remember Daniel? Daniel called 911. First responders came to his home. So paramedics came, police came. And at that moment, Daniel could have been deflected into treatment rather than arrested. Now, what's diversion? So deflection's way, way upstream, right? Diversion is getting folks into alternative treatment or services during their jail intake, their booking, or their initial hearing. So in lieu of conviction or traditional sentencing. So one is the first contact with law enforcement. Can we deflect you? One is diversion. Instead of being sentenced, we realize you're screened, you have mental health issues, you could use treatment. Let's divert you into treatment instead. So in the next slide, we're just going to spotlight a few of the things that we currently fund that we're looking at now with the new funding. Some of you may have heard of the LEAD program before, which is law enforcement assisted diversion. So we highlighted and we spotlight some of the places like at Coastal Horizons or the Buncombe County Sheriff's Office, where people get diverted to community-based treatment services rather than go to jail or be prosecuted. People have probably heard of the Mental Health and Policing Initiative, and this is where social workers and or clinical care managers are embedded in law enforcement agencies, and they can support pre and post arrest diversion. We have some wonderful examples in Orange County. We've got Agape services in Washington County. I don't mean to not shout out all the wonderful things that are happening across the state, but wanted to give you some examples. And then we have co-responder models. So last month, excuse me, we talked about 988, which is an alternative crisis response, right? We want folks to call 988, but folks will still call 911. So how can we have co-responder models? So when law enforcement and paramedics go out, a mental health professional also goes out, or they're triaged to go out when someone calls 911, and we're able to divert folks into treatment at that crisis point. And the HEART model in Durham is a really wonderful example of that. So again, shout out to some folks here, but there's lots of folks in the state doing really creative and wonderful things. On the next slide, I wanted to just show you a map of where we have some programs. Now, the first thing you're going to see about this is we don't fund programs everywhere. We absolutely do not. And that's one of the things that we're looking at, right? What is, with the limited dollars we have, what is the most effective way to think about how we fund things? But this is just a map of counties where we have the 25 deflection and diversion programs that we fund. Some are very specific to substance use, some are specific to mental health and substance use. So they're not always whole person, totally comprehensive, but they do involve getting folks into treatment and getting lots of care management or case management. Many of these programs involve massive amounts of case management, helping people get transportation, jobs, healthcare, behavioral healthcare. Lots of that is part of all of these models. So that's deflection and diversion. The next thing I'll talk about, and I'm going to remind you of Daniel again. So remember Daniel, he didn't have treatment prior to his crisis. He had a first responder come and he got involved in the justice system. So he could have been deflected there, but he wasn't. He didn't get diverted. He got sentenced and he went to jail, but now he's in jail. And he needs something called capacity restoration. For those of you who don't know what capacity restoration is, so sometimes a defendant, a person in jail, has a mental illness, and the courts say, this is the court term, not mine, you're incapable to proceed. You cannot proceed to trial. You need mental health treatment first. You are not in the right mind space to be able to go to trial. So people wait. Up until about 6 months ago, people had to wait, or maybe a year ago, excuse me, time flies here. People had to wait to get a bed in one of our state facilities to get this capacity restoration, this treatment service. So then they could go to trial. And that's a long time. So you're a person who's in jail, maybe longer than you needed to be because you're waiting for treatment. So Daniel was waiting for treatment before he had a crisis, before he got arrested, and now he's waiting for additional treatment because it's so specialized. He needs his capacity restored, and he can only get it in a few places in the state. So we have partnered here, and all credit to my colleagues at the Division of State-Operated Healthcare Facilities, Bob Cochran and Karen Burks and their team, for partnering with Mecklenburg Sheriff's Office to develop a community-based restoration program. It started in January of last year. It had 10 beds and it was immediately full. Mecklenburg is expanding and some other counties are considering this. It's very cost effective. So if you look at the bars on the right, red is how much a state hospital bed costs, and blue is how much these community capacity programs cost. So it's very cost effective. But the better thing is people who are incarcerated, who need treatment and who need that treatment so they can go to trial and go home, just get treatment a lot faster and are able to, we want them to get treatment faster, but they're able just to reduce too their time to getting actually going to court and getting sentenced and serving their term. So it's a really wonderful thing in terms of getting people the treatment they need, but also it's very cost effective for our system. So that is a treatment while incarcerated. So the last thing I want to talk about today, and I think we'll have a lot of good time for questions today, is the last thing I want to talk about are our reentry programs. We have lots of reentry programs in the state, actually a lot, and I'll show you a map in a bit. So what on earth is a reentry program? A reentry program is someone who's coming out of jail or prison who needs help transitioning back into the community. So this might be a person who was fortunate to get treatment while they were incarcerated, and that could be everything from substance use treatment to mental health treatment to even mobile medication assisted treatment, so medication for their opioid use disorder. Maybe they weren't. But the reentry program helps them stay or get connected to the treatment services they need, but also to the other life supports that they need, which is a huge deal for anyone who has experienced this themselves, work with folks who experience this. Transitions are really challenging times, but if you have ever done, I had the pleasure with my team to do a reentry simulation for folks that are coming out of prison, getting back into the community. And it's really hard to navigate getting all of your treatment services in place and finding transportation and getting a job and getting an ID and getting a place to live. It's a lot. It's quite challenging, and reentry programs really help folks be successful. So remember some of those statistics that we talked about back at the beginning, where folks who are 40 times more likely to die of overdose after coming out of prison, right? So this is a really challenging and stressful and sensitive time for folks. So I want to spotlight a couple programs. We have lots of reentry programs, as I said, but I'll just spotlight a couple. One is a really well-known program we have here in North Carolina is our UNC Fit Wellness Clinic. So this is very specific to the Wake County. We accept, or excuse me, it accepts people released from state prison. These folks have severe mental illness and complicated issues. And I have those on the slides on purpose because folks sometimes have very complicated issues. Some of the reasons they take people are, besides they have mental health issues, they have a history of treatment on compliance. I'll put that in quotes. Sometimes aggression, recent solitary confinement. So these can be the more complex of individuals coming back to the community. And this service does provide both psychiatric, but also physical health care and peer supports. It's a really wonderful blend of services to get people connected back into the treatment they need for wellness and recovery, but also helps with those transitions for housing and a stable place to live and employment. Really, really good program that's showing lots of promising returns. It's an evidence-based model. On the next slide, I'm going to highlight one more because this one's really critical. We have this program now in 14 of the, it's associated with 14 of the 56 Department of Adult Corrections programs here. And this program, I want to give a shout out to my colleagues at the North Carolina Council of Developmental Disabilities. They funded this program as a pilot years ago, and now our division has taken over the funding of it, and we hope to expand it. This is a re-entry program for people with intellectual and developmental disabilities and traumatic brain injury. So this is a really critical program, and it has really incredible success rates. So we just began to maintain the program in October of this year. But prior to that, they had wonderful rates of getting folks connected to services and supports in the community, and wonderful rates of reduction in recidivism. So over 80% of people were not getting rearrested and going back into the justice system. Instead, they were being stabilized in the community, which is really exciting. So just like other reentry programs, it gets people connected to services. It also really focuses on skill building. So again, these are specifically trained care managers who help folks maybe build skills to be able to maintain in the community in healthy ways and maintain housing and work. It's very person-centered. And it also provides, which I think is really nice, it provides education to some of the adult correction staff. Because again, I think we've been working for some time as a nation and as a state on making sure that folks who are incarcerated get mental health treatment and substance use treatment, and that we're all comfortable using medication-assisted treatment for opioid use disorders. But, there's a lot of work to be done there still, but making sure that folks understand folks with intellectual and developmental disabilities and how to meet their needs while they are incarcerated is a big deal. So being able to train Department of Adult Correction workers in that space is really exciting. So this is in 14 places now. We'd like to expand it to more. And one of the areas that we hope to really expand with some of these dollars is not just reentry, but some of that deflection and diversion we were talking about. So having deflection and diversion programs specifically for adults with intellectual and developmental disabilities. Now, before I kind of wrap up and tell you where we're going with our working groups, I want to say one more thing. This is, again, just an overview and a snapshot. Some of the things that we are still working on that I know that are really important to y'all, or one really big thing I want to talk about is juvenile justice. So we get some juvenile justice funding, and some of this funding that we got from the General Assembly will absolutely be used to look at where we need to enhance our partnership with juvenile justice and services for youth. So these aren't just services for adults, it's services for youth as well. So this is a topic we'll probably be able to revisit with you all. We got money, also remember, we got money for children, adolescents, and families in the budget. So we will be talking more specifically about family-focused, adolescent-focused services, and know that juvenile justice is one of the areas that we are also working on. So we'll be able to give you an update on that in the future. So on the next slide, this is our map of where we have reentry programs. We have 49 of them, so there are a lot of those. I forgot to tell you before the color coding, if you can see it on the side. In some counties, we only have one program, and others we have more programs. And so the colors on the counties correspond to how many programs we have in each county. But again, you're going to see lots of counties that don't have any of our funded programs. Doesn't mean they don't have anything, just means they don't have our funded programs right now. So part of what we're doing, besides meeting with a very eclectic advisory group, is also to look at data on the current programs that we're funding, the kind of outcomes that we're getting, but also other types of data in the state where we have some of our largest prison and jail populations, where we have services or not enough services in some of those areas. So where would be the best, most strategic places to infuse some new funding into some of these continuums of care? All right, on the next slide. So I want to let folks know what we're asking our community partners, and we have plenty of time today for question and answer. We've been trying to work on that to make sure that we have plenty of time for that every month. But this is actually a slide that we used when we met with our community partners. And let me just unpack community partners. So it's not just us at the state sitting around and talking. It certainly is, but know that at the state, we've also asked sister departmental agencies to come. So adult corrections, juvenile justice, the AG's office, so the Department of Justice, but also county entities, right? Administrative Office of the Courts, counties that are involved in this work. We'd love to have the Sheriff's Association come. Providers, there are so many providers that provide mental health and substance use services for people along that whole system that I mentioned, everything from deflection to treatment while folks are incarcerated to reentry services. So we have providers all across the spectrum. Our LME MCOs, of course, they're doing lots of interesting things in the justice reentry space and other pilots. So we've got a really eclectic group of folks. And what we're asking them, of course, we're saying, what are some real pain points in your communities, but what are some pride points? Because we want to know the things that are working so we can embellish on them. And we are asking across the board, so children through adults and across all the people we support with mental health, intellectual and developmental disabilities, substance use disorder, traumatic brain injury, and people with co-occurring illnesses, a place that we need to really strengthen our resources here in North Carolina. Where should we invest? It's a huge question. It is a huge question. But we're trying to be really smart, really thoughtful, really inclusive when we're getting feedback. And using all the data that we have to make some of the best investments that we can. So these are some of the things that we're asking our community partners. So that is actually my last formal slide. That was a lot of material to cover. We tried to be judicious and not tell you all about the, oh mercy, it's probably 70 to 80 programs that we fund across the justice continuum. But we wanted to give you a highlight of what we are doing and know that we will be unpacking this in our regular monthly groups and in our advisory groups every month. And I think now Sarah's going to join me on screen because we left lots of time for Q&A. And remember, Q&A can be about any of the stuff that we talked about, any of the announcements that we talked about, or whatever. We will do our best to answer. Sarah, do we have any questions teed up?
Yes, we do. And thank you so much for everyone who's been asking questions. Many of you, we have typed in the answer, so you've already received the answer. But we will pick some of the questions and do live answering here. So the first question is for Tina Barrett, our IDD team lead. The question is the increased pay for DSPs. Would that also include those DSPs for 1959 services, or is it only for innovation waivers?
And unmute myself. Thank you, Sarah. For right now, those increases are slated for our recipients who have innovations waiver and not for others at this time.
So can I add to what Tina said? For the eye option services, please look at the behavioral health rate increases bulletin, everyone, because the DSP article is very much, as Tina said, very much about innovations waiver increases. Therefore, with the behavioral health rate increase dollars, we also increased rates for 1915I services and 1915B3 services, because what we didn't want to, same outcome, different buckets of money. Because what we didn't want to do is to increase one and not the other, right? So we wanted to balance this out. So yeah, DSP, as Tina said, for innovations, but we use some of the behavioral health money to bring up the eye option and the 1915B services.
Thank you. The next question is, how can we support getting law enforcement officers trained to effectively support people in the community who present with mental health challenges and or behavioral challenges related to IDD or autism?
That's a great question. I don't know if Stella, Tracy, I don't know if Scott is here, because there's a lot of work around officer training. And I know there is some, it might be more targeted, but there's also officer training or for folks about helping folks with IDD and autism, but they are the experts.
They are, thank you. That's a really good question. We do crisis intervention team training for our law enforcement officers. And that includes specific training modules for related to IDD and TBI. And Tracy Ginn, who is leading that initiative, has put herself on camera. So I will let her talk about this, more about this initiative.
Yes, so the CIT training is that evidence-based model for training for law enforcement and first responders to help de-escalate behavioral health crises. And that includes individuals who might be in crisis from a TBI or IDD. The trainings are done through the MCOs, and they're 40-hour training, and there's specific modules within the training that do address individuals who have TBI and separate modules for individuals who have IDD. They include in every CIT training, there's also individuals who are family members or individuals with lived experience who participate and help with the training in the CIT classes. So we really try to be inclusive to everyone who might have those kind of challenges. Then we address all their needs as well.
Thank you. There is another question, and this would be open. Kelly or anyone else can answer. What is the timeline of the final transition of Sandhills, East Point, and Trillium? I know that Tailored Care Management is supposed to be fully operational sometime in the first quarter of the new year, and the 4 MCOs are supposed to be operational prior to Tailored Care Management being operational.
Hey, Sergeant McCoy, I can take this one. So Tailored Care Management has actually been operational since December of last year, but we understand it can be difficult to keep all of our terminology straight, tailored plans versus tailored care management. So I think that was a good opportunity to clarify that. So tailored plans by legislation are intended to go live by July 1 of next year. And that is the timeline that we are working towards. But the LME MCO consolidation is intended to be operationalized by, well, we're supposed to have it finalized in January, sometime in January, and then anybody affected by having to move would be moved on February 1st.
Thank you, Dr. McCoy. I think we can take one more question. How do we ensure the needs of transition age youth are not lost between juvenile justice and criminal justice systems? Since we know there are also a high number of people with IDD in the justice system, how do we ensure people are assessed for IDD and mental health and SUD at entry or absolutely before exit?
Who wants to take that? Stella, you want to pick that one? Or whoever.
I do want to take it. Could you repeat that for me, please, Sarah? Because there are lots of aspects to that.
That's right. That's right. How do we ensure the needs of transition age youth are not lost between juvenile justice and criminal justice systems? And then also that we know that there is a high number of people with IDD in the justice system, and how do we ensure that people get assessed for these IDD, mental health, and SUD at entry or at least during before exit?
Mm-hmm. This is something that is incredibly important, particularly the transitional age youth discussion. And I know that our partners between our DJJ colleagues over at DPS, our colleagues in DSS and the Division of Child and Family Wellness. Apologies if I have your divisions and agencies are not tripping off the tongue, but we are looking at that very closely. It's incredibly important. And the way that we ensure that we are doing that work is through this cross collaboration. We have opportunities now, particularly with our investments, where the best investments are specific to build collaborations locally and within our infrastructure to work better together. And that means more training for our law enforcement officers and anyone within the court system. And that includes training on assessments, high quality assessments using good tools, standardized tools that have a strong evidence base. It also includes all of the work that we're doing with our TBI sections to get more of this information available for folks.
Thank you, Stella. Again, please, we try to answer as many questions as we could with the time, but we'll make sure that if there are any other questions that we can follow up on, we will do that. And I will pass on back to Tina.
Thank you, Sarah. If we did not get an opportunity to answer your question during the webinar, questions and feedback are welcome at bhidd.helpcenter@dhhs.nc.gov. The recording and presentation slides for today's event will be posted on our community engagement and training webpage. The links are included in the chat box. There will be a brief survey following today's webinar, and we would appreciate your time completing it. Our next side-by-side webinar is scheduled for Monday, January 8th from 2 to 3 p.m. And we look forward to seeing you then. This concludes our webinar for today. Thank you for attending.